morning, everybody. Thank you for joining us on Fits on the Go. We have Dr. Scherrer-Crosbie here with us. She is a professor of medicine and director of the Echo Lab at UPenn. And we have Dr. Tomas Neilan. He is the director of the cardio-oncology department at MGH. Thank you so much for joining us in this wonderful morning at ACC. We are extremely excited to learn more about the STOP-CA trial. Would you mind sharing a few words about how the trial was designed, how the trial came to be, and go over some of the main results?
Sure. So we wanted to study whether we could implement a cardioprotective intervention in patients who were treated with anthracyclines for cancer. We chose anthracyclines. They are very common anti-cancer drug, and they have a known cardiotoxicity with left ventricular dysfunction that sometimes leads to symptomatic heart failure. We studied patients with lymphoma, with anthracycline are the backbone of the treatment in those patients. It's a relatively common cancer with a very good survival rate, so we need to worry about later events, and they have a high rate of heart failure, those patients. What we did is that we studied the role of atorvastatin. There are some experimental plausibility and retrospective study, and at the time when we started, a short prospective study that showed some promising results. So what we did is that we treated patients with either 40 milligrams per day of atorvastatin or placebo for a year. And we looked at their ejection fraction before with cardiac MRI and after 12 months, at 12 months. And our endpoint was a cardiac dysfunction as defined by a decrease of 10 points or more of the left ventricular ejection fraction to less than 55%. Our results is that the primary endpoint, so cardiac dysfunction, was reached in 9% of our patients. That was a total of 300 patients that we randomized. So 9% of our patients in the atorvastatin group reached the endpoint of cardiac dysfunction, and 22% in the placebo group reached cardiac dysfunction. That was highly significant. And another way of saying it is that the patients who had placebo had nearly a threefold increase risk of having cardiac dysfunction than the patients on atorvastatin. The patients who benefited most were females, older patients, more than 52 years of age, which was our median, more than 250 milligram per square meter of anthracycline. The patients with lymphoma have a median of 300. That's a high dose. And obese patients. And the intervention was very safe. There was no difference in side effect with placebo. So those are our main findings. Our conclusion is that patients with lymphoma at high risk of cardiac dysfunction benefit from atorvastatin to protect them from cardiac dysfunction.
This is such an important trial with very important findings. I'm just curious, what are your thoughts about trying to use this strategy or cardioprotective strategies for other types of cardiotoxicities? I know we don't really have that much research, but in your personal clinical practice, do you ever use statins or other cardioprotective strategies for patients undergoing cancer treatment?
I mean, generally, I would answer that question thinking about the different potential cardiotoxic therapies that are out there. It is not uncommon to think about women who get radiation treatment for breast cancer as being at higher risk of atherosclerotic cardiovascular disease. And especially in those individuals with radiation treatment, I think of the radiation treatment as an effect modifier. And so for individuals for whom the predicted risk is in the borderline category or maybe even in the normal category, I will talk to them about how we know that radiation treatment, where the cardiac silhouette is involved, that statins, for example, might be beneficial to prevent atherosclerosis progression. That's a very common consult I will have to try and think through that. But it's pretty specific to the type of cancer therapy that you're talking about.
That's true.
For example, I wouldn't think that statins would be protective against immune therapy or immune checkpoint inhibitor-associated myocarditis. There may be some data that statins are protective against checkpoint inhibitor-associated progression of atherosclerotic cardiovascular disease. But the devil's in the detail, as it always is.
Yes, truly. And we need more research to help us find better preventive strategies. If you want to see the full length of the videos, you can go to youtube.com/fitsonthego. Thank you for joining us.